your skin and fascia. It is going to provide the elastic component to the muscle. So if your skin becomes saggy and superficial layer becomes saggy, it is going to pull your muscle down and increase the resting length of the muscle. So that way, as we age, the muscles they cannot contract properly. So this slide shows as we age, the skin it loses elasticity, and at the same time bone and fat loss is happening. So the muscle fibers, the skin has sagged, they are pulled beyond the optimal length. So the length of muscle it increases, it reduces contraction efficiency, and there is impaired facial expression and tone. So this is a continuous cycle. Stretching dysfunction. So with every passing year, the muscles are getting stretched because skin and superficial tissue is sagging. And yesterday we discussed about overfilled face syndrome, and one of the reasons of overfilled face syndrome is when you put too much product in superficial layers. And what happens? It starts adding to the weight of the tissue which is on the muscle, and muscle starts stretching even more. So that actually exaggerates the aging if too much product is present in subcutaneous fat layer. The second mechanism of movement is muscle pulling and lever system. So for any muscle to act on the face, it has to use a fulcrum. For example, zygomaticus major muscle, the spoof, which is the deep fat pad, it acts like a pulley, and zygomatic arch is a fulcrum, and then when the contraction happens, the fixed point is zygomatic arch, but the gliding which is happening at the level of spoof. So the deep fat pad, they provide a gliding plane for us on which the muscles can move. And third mechanism in facial movements is balance between functional group. So we have levator muscles which lift the soft tissue, and then we have depressor tissues which pull down the facial tissue. In youth, the levators are dominant. So face is lifted upwards, there is a nice contour, whereas in aging, the levators they become weak and depressors they become strong. So that way you have saggy and sad expression with age. So when we talk about functional groups like agonist and antagonist, most of the studies were done in the upper 1/3 of the face, because we have been using toxins for so long. So here we know about how frontalis is an elevator, and all the other muscles, be it corrugator or orbicularis, oculi or procerus, depressor supercilii, they are all depressors. So we knew about this thing, and we used this knowledge for injection of toxin in the upper 1/3 of the face. But not much thought was given to modulating the mid-face and lower face muscles using filler before the myomodulation concept. So in this you can see a force is being applied on depressor muscle, which is DAO, and at the same time on zygomaticus major muscle. So when we are young, the zygomaticus major muscle is stronger, so your mouth corners they are lifted upwards. As we age, the DAO, depressor anguli oris, it becomes stronger, and the mouth corner they start drooping. So this is the mechanism of how facial agonist and antagonist muscles they work. And if we see here carefully, the zygomaticus major muscle on the top is very thin, whereas DAO, DLI, mentalis and platysma, which are all pulling the structures downwards. they are much stronger. And as we age, as the chin starts receding and the platysma becomes stronger, everything starts moving downwards. So what is the myomodulation? It is the mechanical modulation of facial muscle activity using HA filler to either increase or decrease the muscle action by altering the structural relationship between muscles and the surrounding structure. So the perfect example of myomodulation is my shirt. It is so small, it has restricted my chest expansion, so I can't breathe fully. Same way, when a filler is placed on top of the muscle, the power of the muscle reduces. So I'm going to explain how by placing filler above or below the muscle can reduce or increase the power of the muscle. Traditionally, fillers are mainly for restoring volume and correcting static wrinkles, whereas neuromodulators, they were mainly to reduce overactive muscle, but now the role is changing. Now we are using fillers for myomodulation. How does it happen? When we use deep filler, it acts as a fulcrum. It facilitates contraction by lever and pulley method. If we put fillers in the superficial plane, it blocks. Like if we put weight on this cycle, so the speed of the cycle becomes slower. So that way, by putting filler on top of the muscle, we actually inhibit the overactivity. When we place filler in the depth, perfect example is zygomaticus major muscle. When we place it under the muscle, it supports the muscle, it achieves optimal tension, and it also acts as a pulley. I'll show you the drawing. So here you can see in normal youth, there is adequate amount of fat in the deep fat pad. The anchor point is at the optimal position, but as we age, the muscle it becomes longer, so it gets stretched. So the optimal contraction of the muscle is not happening. So again, by replacing the fat in the deep plane, by putting the filler bolus, we can lift the anchor point upwards, have optimal length of the muscle fibers, and the muscle again starts contracting normally. On the other hand, if we want to dampen the muscle activity, for example, in case of gummy smile for depressor septal muscle, overactive mentalis, which is QD orange, or there is DAO hyperactivity, which is downturned mouth corners. In all these cases, by putting filler on top of the muscle, we can actually reduce the power of the muscle. Which are the key muscles in myomodulation? So we have LLSAN, orbicularis oris. Then we have DAO, zygomaticus major muscle, orbicularis oculi. And in the next slide, I'll show you depressor septi also. So these are some key muscles which we target while we are doing myomodulation. Here again, you can see LLSAN right next to the ala, zygomaticus major, rhizolius, DAO muscle. Here the modulus can be seen very clearly, where all the 7 muscles they are inserting. You can also see mentalis, DLI, DAO, platysma, rhizolius, orbicularis oris, and levator anguli oris. So these all muscles which are present in the vicinity of DAO or which insert into the modulus, they are the ones which we basically target during myomodulation. So what are MD Diana codes? MD codes, they taught us where to inject, whereas MD Diana codes, they taught us what muscle actions we need to target, and how can we modulate these muscle actions by using fillers, not toxin. So these are the legends which are used in MD Dyna codes. So where you see arrow upwards, it's basically facilitating the muscle contraction. Arrow downwards is reducing the muscle contraction. Similarly, by changing the muscle resistance, either by blocking, so this lock shows just like putting a stone behind the car, and tensile strength is by optimally improving the length of the muscle fiber, we can improve the function of the muscle. So what are the functional aims of MD Dyna codes? It facilitates the weakened muscle by improving the leverage or the tension of the muscle. At the same time, it resists or blocks excessive contraction by placing it on top of the muscle. So it can be above the muscle, below the muscle, or rarely it can be injected in the muscle. So these are the legends. If it is above, it is M, there is a bar above, below into, and the angle of injection could be from less than 30 degree, which means you are placing it very, very superficial, to 90 degree, which means you are going under the muscle. So injection depth is very important. It could be subcutaneous or supraperiosteal. Injection angle could be less than 30 degree, as I said, and go almost 90 degrees. And we can use cannula or needle depending on which area we are injecting, whether we are close to some important vessel or not. So these are some of the muscles which are impacted when we do a specific area. For example, when we do CK3, so this whole region is injected, then levator, LLSAM, levator labiae superioris, and zygomaticus minor muscle. These three muscles, which are mainly responsible for causing gummy smile. By injecting the medial side of CK3, we can target all of them. But if you see, the angle is less than 30 degrees. That means it is placed in more superficial plane, not in the deep plane, because we are trying to reduce the activity of these muscles, not enhance it. Similarly, N1 is a nose code. So depressor septi muscle just here below the nose. When it is injected at 90 degrees. That means right on the bone. So again, here the action is mainly by blocking. So the bolus of the filler, it acts like a block to reduce the power of the muscle. Similarly, if we are doing NL1, which is very medial, it is only LLSAN, NL2, we go slightly lateral, it is LLS, levator labiae superioris, NL3, further outwards, it is zygomaticus minor. Then when we are doing LP8, so in that levator labiae superioris, and also it's not mentioned here, orbicularis oculi muscle fibers. They are all, if we inject superficially, they are all impacted. LP1 again, it is mainly orbicularis oculi, orbicularis oris muscle is the one which is impacted. So when we come in the chin area, C1 mainly in this part, depressor labiae inferioris. So DLI is the target muscle when we are doing the C1 injection. And JW4, it's DAO and DLI, and JW5 is mainly DLI. So this way, we can use the knowledge of muscles by using these Dyna code table. We can use our knowledge of placement of fillers, how to change the power of these muscles to our advantage. First case which I am showing is a young Asian patient with anterior nasal spine and premaxillar deficiency. where the columella is retruded and underdeveloped midface, so that leads to a gummy smile. So all these muscles, hyperactivity of upper lip levator, LLSAN, LLS, zygomaticus minor, depressor septi, they are all involved. And just seeing by doing single injection of 0.7 ml of voluma at depressor septi, only one muscle, has improved the smile. So this is the depressor septi muscle and this is LLSAN. You can see just by doing one injection, it improved the smile. Again showing depressor septi muscle, LLSAN. And the other commonly used area where we use myomodulation is the lower face. There is a case where there is chin deficiency. So 1 ml per side was used in labiomental angle, which was C1 to block DLI muscle, and 2 ml was used in chin apex, mainly to block mentalis. So by using 4 ml of voluma, using a combination of deep injection as well as fanning in the subcutaneous plane. Deep injection to provide support, to give projection because there is bony deficiency. Superficial injection to dampen the activity of mentalis muscle because there is excess contraction of mentalis muscle which is showing through the skin. Here we can see the fibers of mentalis. They are coming from the bone, the canine fossa, and it's coming like a hockey stick. It's coming and inserting into the chin skin like this. So we have to inject very superficially using cannula in the chin area to cause the damping action of myomodulation, to reduce the power of the muscle. At the same time, structural support is provided by deep injection on the bone where very few mentalis fibers actually reach. Because all of them, before they reach the bone, they have all of them they have curved and inserted into the skin. Very few fibers they go in the lowest part of the chin where the bone is. It starts curving way high. As you can see, they are coming like this and inserting into the skin through superficial fat compartment. Again you can see mentalis muscle, DLI, DAO, and very clearly you can see intersection of all these muscles, and the modulus is very clearly seen in this photograph. Why myomodulation? It matters clinically. It enhances animation and expression. It restores the natural balance between various muscle groups, so that leads to enhanced facial expression. And it very well complements neuromodulators. So areas where we can't use toxin, or in some areas, for example, in mentalis where there is tight chin, we can use a combination of fillers as well as the toxin to improve the appearance. So what is clinical takeaway? So rebalancing is more important in some areas than simple relaxing. So you may be just tempted to put some toxin along the jawline or in the platysma or in the DEO area, but then just relaxing sometimes is not enough because then you are just targeting the depressors. So you need to target the elevators also at the same time. So rebalancing is more important than simple relaxing, and we need to treat the structure to improve the function by providing adequate support. By improving the bony structure, we can actually improve the function of the muscle. And fillers can be used both as levers, that mean to facilitate the movement of the muscle, as well as used as brakes to reduce the power of the muscle. biomodulation is a philosophy of restoration. We can use anatomical depth as well as anatomical location of various muscles to improve the muscle interaction. With that, we end the first presentation. Thank you. And now I invite my dear